Hello everyone. So we will be starting with contraception. Today's class topic is contraception. Am I audible and visible? Please give the thumbs up if I'm audible and visible. Hello everyone. So we will be starting. Shahrukh Turk, hello. Please give the thumbs up if I'm audible and visible clearly. Okay, so let's start it without any delay. Okay, starting with contraception. First of all, I want to tell you contraception is studied under two topics, reversible and irreversible. Okay, reversible methods are uh, usually a matter of choice what to take and what to not to take. In irreversible, we have only two methods, tubectomy and vasectomy. Okay, if a female wants, then she can go for tubectomy. If a male wants, he can go for vasectomy. And if the only indication if they think that their family is complete. Okay, now, talking about the reversible, the most frequently questions are asked on copper-T and combined oral contraceptive pills. Okay, so we will discuss this in detail, and other topics we are just going to touch. Why the questions are asked only and only on these topics? Because this is what is available or free to the citizens of India by the government. These are the only two methods which are available for free. Okay, so you have to be thorough with the copper T and combined oral contraceptive pills, each and every point. Okay, let's start it. This is a question from FMG December 21. Tell me which of the following is absolute contraindication of copper T. Options are unexplained vaginal bleed, history of previous PID, history of previous ectopic, HIV positive status. Do answer this question. For example, a patient has come to you, I want copper T to be inserted. What all factors you will rule out? As I already said you, we have only two methods of contraception. Please write down in the chat box what you will, what are the absolute contraindication. Yes, it's A. ISRO, it's not history of previous ectopic. We will discuss it soon, but it is not history of previous ectopic. The answer is unexplained vaginal bleed. Any other? Shahrukh and Isaac, you are correct. Answer is unexplained vaginal bleed. Now let's discuss. Okay, the contraindication of copper T should be very and very clear to you. That is why we have a mnemonic, and the mnemonic name is India Top ABCD. Okay. First of all, these are the contraindication, and you should know what I stands for. I stand for infection. Okay. But which infections? Only and only pelvic infections, not each and every infection. Okay. So, which are the pelvic infections? PID and puerperal sepsis. Okay. And plus, this should be active. Both should be active. Okay. If there is a history of previous PID, ISRO, then why you will not put? It has been treated. Every female has PID history. Cervicitis do occur, right? So please write down it is not a history of previous PID or history of puerperal sepsis. It is the active, if the patient is having active PID or not. Okay. Next is T stands for trophoblastic diseases. I always tell you that in a patient of trophoblastic diseases, that is molar pregnancy, only in molar pregnancies, complete mole or partial mole, after doing suction and evacuation, patient should take contraception, because patient has to be followed up for the rise of the beta HCG, whether that molar pregnancy is changing into neoplasia or not, cancer or not, right? So, in due to that, the patient is given contraception, but copper T is not given. Okay, copper T is contraindicated. Can anyone write down in the chat box why copper T is contraindicated in the molar pregnancy patient? Can you give me a reason? Yes, Isaac, it is right. It is contraception is given for 6 months, and follow up of beta HCG is also done for 6 months. Why copper T is not given to the patients of trophoblastic diseases of molar pregnancy? Can you write down in the chat box? Because once we know the reason, we don't forget it. Because the uterus is very soft. If we will put the copper T, it will perforate the uterus. Okay, and why pregnancy is not allowed for 6 months? Because in pregnancy also the beta HCG rises, and in gestational trophoblastic neoplasia also the beta HCG rises. So we will not know that whether this rise of beta HCG is due to the contraception, or is due to the pregnancy, or due to the neoplasia. Okay, do you understand? Now A stand for anomalies of uterus, not the anomalies of vagina, not the anomalies of cervix. So what are the uterus anomalies? Biseptate uterus, bicornuate uterus, and uterus diadelphus. Are you getting? And why copper T is contraindicated in uterus diadelphus, bicornuate and biseptate? Any guesses? Any guesses why copper T is contraindicated in biseptate, bicornuate and uterus diadelphus? Any guesses? It is contraindicated because there are two uterus cavities, okay, and we cannot put two copper T's in them. Okay, we can insert but there are two cavities, we cannot insert two. Okay, we cannot insert two copper T's. So if we know, Isaac, it is not high chance of ectopic. No. Okay, please don't interfere your ectopic with, as you are seeing that I am having a copper T contraindication full chart, but here nowhere I have mentioned the word ectopic. Okay, so Isaac, never you will say due to the fear of ectopic, because when we have put the copper T, pregnancy will not occur. So copper T will also not occur, right? Never say due to ectopic. We not put the copper T in the case of biseptate, bicornuate and uterus diadelphus, because we cannot put two copper T. If we put copper T in one cavity, then the pregnancy will occur in the other cavity. Okay, so pregnancy will not be prevented. That's why. All of you got it? B stand for undiagnosed vaginal bleeding. Why we don't put copper T in undiagnosed vaginal bleeding? The reason is that it can be of any etiology. It can be a cancer, it can be simple menorrhagia, anything. And when we put copper T, the bleeding increases. So we will increase the its bleeding tendency. First of all, the problem is undiagnosed. Okay, even if it is simple menorrhagia, most common cause is bleeding. Yes, when we insert the copper T, most common cause of expulsion of copper T is Shahrukh, bleeding. Uh, Sorry, most common side effect is bleeding. Most common side effect of copper T is excessive increased bleeding. Okay, and when we will put the copper T, then the bleeding will increase. Okay, and you are not going to put the copper T in a uterus where something is undiagnosed. Okay, C stand for cancers, only two cancers, uterus and endometrium. Here nowhere vagina and cervix is written. D stands for diabetes mellitus with vasculopathy, not in a normal diabetic patient. Not in a normal diabetes patient. Is it okay to you? Okay to all of you? Should we move to the next slide? Okay. Now you will not forget it. India's top ABCD contains none other than this is the contraindication of copper T. Only these six, I, T, A, B, C, D. Next question. All are absolute contraindication of combined oral contraceptive pills except. Please answer. Please answer. All are absolute contraindication of combined oral contraceptive pill except. Yes, Shahrukh, it is STD. Okay, now let's yes, STD. Answer is STD. Okay, Isro, you are also right. Answer is STD. Now we will quickly revise what are the all the contraindication of combined oral contraceptive pills. Okay. First of all, combined oral contraceptive pills contains both estrogen and progesterone both, right? And estrogen has a typical characteristic that estrogen increases the coagulation factor. Okay, and that is why the list of combined oral contraceptive pill contraindication is so long, right? Because the most common problematic thing with estrogen is that estrogen increases the coagulation factors. Okay, now what are the conditions in which already the patient has increased coagulation tendency is told to us by Varsho triad. Do you remember Varsho triad from the patho? Do you remember? All. Okay, so there are three components of Varsho triad. Endothelial damage. The one who has endothelial damage will have increased tendency of coagulation. Okay. There are, I didn't get you what you're writing. Varsho triad was given by Varsho that if there is endothelial damage, stasis, and increased hypercoagulability, then there will be increased tendency of the patient to form clots, get undergo clotting, right? So what is the endothelial damage? In which conditions the endothelium is get damaged? In smokers, right? Smoking breaks the endothelium. In and what is the in criteria for pure smoker? More than 18 cigarettes per day. There are some areas in India where females smoke a lot, right? So we cannot, they smoke bidi particularly. Okay, so therefore we have put a criteria. A smoker is one who smokes more than 18 cigarettes per day. Hypertension also do damage to endothelium more than 160 by 100. Not each and every hypertension. Then again, diabetes with vasculopathy, not normal diabetes. Okay, and number fourth is migraine with aura. Migraine with aura. Now you know all these four factors: hypertension, diabetes. You know these two things. You have just to learn smoking and migraine. Okay, smoking and migraine. You have just to learn smoking and migraine. Hypertension, diabetes, you know that when hypertension is more than 160 by 100, when diabetes mellitus with vasculopathy is there, then endothelial damage occurs. You have to just learn smokers and migraine. Number two is stasis. Stasis occurs, blood flow decreases in heart diseases, right? In atherosclerosis and hyperlipidemia. Okay? In heart diseases, atherosclerosis and hyperlipidemia. With aura, what is it? It is a typical stage of migraine. Okay? I think medicine people will help you. Migraine with aura, it's a typical stage of migraine. Okay? Stasis occurs in blood flow velocity decreases in heart diseases, right? And any heart diseases. It can be ischemic heart diseases, it can be valvular heart diseases, it can be rheumatoid heart diseases, any heart diseases. Okay, atherosclerosis and hyperlipidemia, they also slows the blood flow, right? Next is hypercoagulability. Already the patient had hypercoagulability. Okay, the condition is if the patient has already thrombophilia, history of thrombophilia is also to be encountered here. History of thrombophilia, hereditary or thrombophilic diseases, right? And this is very, very, very important. Postpartum 6 weeks. Postpartum. You all know in the pregnancy, the coagulation factor increases. Do write in the chat box which two factors does not increase in pregnancy. All coagulation factors increases in pregnancy. Which two factors does not increase in pregnancy? Write down in the chat box. This is a very frequently asked question. No, Shahrukh, it's not 8. Which all the coagulation factors increase in pregnancy except 2. You have to tell me which factors are these. 4-5 times question has been asked. The answer is 11 and 13. Now you all know, please write down except factor 11 and 13. They decrease in pregnancy. Write down in the chat box 11 and 13. All those who are watching, please write down. A sure expected question is there on this. Not 11 and 12 ISRO, it is 11 and 13. Do correct it. Isaac, do write down 11 and 13. Okay. Okay. So 11 and 13, only these two factors. Which coagulation factor increases, due to which increased coagulation factor the ESR increases in pregnancy? Yes, please write down. In pregnancy, normally the ESR is near 50, due to which increase increase of which coagulation factor causes increase in ESR? This is again a sure expected question. Yes? No, it's not factor 9. Any guesses? It is fibrinogen. It is fibrinogen. It is fibrinogen. Okay? Fibrinogen increases. That is why the ESR in the pregnancy, when you will get the pregnant lady ESR done, you will always find its her ESR in 50, 60. Okay, so that is why there is increase in ESR due to increase in fibrinogen. Okay, now all these factors, they increase in pregnancy. Now you tell me that when they come to normal, after, when all this coagulation factor comes to normal after 6 weeks. So that is why in the postpartum phase, they are contraindicated. Okay, because in the postpartum phase, 6 weeks, postpartum 6 weeks, it is contraindicated. Okay, so these are the list due to the increase in coagulation factor caused by estrogen. Now let us go to the another problem of liver active diseases. Okay, liver active diseases. As estrogen and progesterone both are metabolized in the liver. As estrogen and progesterone both are metabolized in the liver. So if the liver is having any active diseases, please mind it, I'm not telling any chronic diseases, I'm telling it active diseases. Okay, so if I'm not telling cirrhosis, okay, active liver diseases, active liver infection, like this, right? Cirrhosis is a chronic diseases. So we will not give the combined oral contraceptive, because combined oral contraceptive pills will not be metabolized. When they will not be metabolized, they will produce toxicity. Okay, next, last but not the least, is lactation. Only 6 months it is contraindicated. This 6 months is very important. And why it is contraindicated in lactation? Because estrogen decrease the milk production. Only for 6 months it is contraindicated, because the estrogen decrease the milk production. After 6 months, estrogen does not interfere. After 6 months, estrogen does not interfere in feeding. Okay, in lactation, no effect of the estrogen after 6 months. This was a question, it was today in the quiz also, and it is in the NEET PG 22 question. Attempt it, please. Yes, Shahrukh, it is correct. Mala N, because Mala N will after 6 months does not interfere with lactation, and the periods will also get regular. In spite of heavy periods and irregular periods, it will also be regular, right? So you will do it right next time. You have done it today itself. Right, good. Now let us go to the next. What are the mechanism of action? What is the mechanism of action? How combined oral contraceptive pills act? Combined oral, when we are taking combined oral contraceptive pill, giving the patient combined oral contraceptive pill, patient takes it orally, right? And then it goes to each and every part of the body, right? And what is the action of combined oral contraceptive pill? Istromala means combined oral contraceptive pills. It is given by the government free of supply. Estrogen and progesterone pill. Mala N, Mala D. These are the government of India free supply. What is the action of combined oral contraceptive pill at hypothalamus? Yes. Please be active. What is the action? Can anyone write for me? What does the combined oral contraceptive pill do on hypothalamus? Yes, it inhibits. So no, it stop. It does not. Yes, yes. It decreases GnRH. It stops the HPO axis as whole. So no FSH, no LH. Very good. No FSH, no LH. Now, if there is no FSH, then no follicle will be stimulated. Follicle will not be stimulated. No ovum will get ready. And if there is no LH, then there will be no ovulation. Do you get it? Now, what is the effect on... Yes, Shahrukh, you're right. What is... You want to ask Shahrukh what is artificial period? Please type in the box yes or no. What is the effect of combined oral contraceptive pills on the tubes? Fallopian tubes. What is the effect? What is the effect of combined oral contraceptive pills on the fallopian tube? I haven't talked about artificial period or pseudo menstruation period. I'm just asking you what is the effect of combined oral contraceptive pill on hypothalamus. So the effect is that it inhibits the HPO axis because it does not let it active. So FSH and LH are decreased. Okay, Mohammed Anas, you have write down the decreased mortality. Can you tell me why? Here I would like to tell you, estrogen increase the mortality and progesterone decrease the mortality. Right? Isn't it? So why the estrogen and progesterone, when given combined, they decrease the motility? The answer to this query is that because the natural estrogen which we are giving is very, very less as compared to the estrogen which was produced by the HPO axis. Okay, The estrogen which is given to the uterus by oral pills is very, very less. Okay, and it is very, very less. And progesterone is of almost the same quantity as that is produced in our body. Okay, progesterone is of the same quantity. So progesterone effect super means, so there is decreased motility. Okay, okay. So decrease motility in the case of progesterone. What will be the effect on the mucus? Estrogen increases the mucus and progesterone makes the mucus thick. Isn't we studied? So what is the effect on the mucus? Again, progesterone effect. Write down in the chat box if a patient is taking combined oral contraceptive pill. There is no question, beta, Rahul. Here there is no question. So cervical mucus, what will happen to cervical mucus? Estrogen makes the cervical mucus thin and progesterone makes the cervical mucus thick, because progesterone makes it thick. Okay champ, makes it thick. So yes, so sperms will not penetrate. Okay, so it makes the, what happens on endometrium? Now you tell me, what is the effect of combined oral contraceptive pill on endometrium? Please write down, interact fast. Please write down, what is the effect on endometrium? No, I already told you, Shahrukh, progesterone effect will supervene. Endometrium will be thin. Yes. So you have to write here, less proliferative. Write down, Shahrukh, less proliferative. Because estrogen is less. And Shahrukh, endometrium less proliferative. Estrogen is less. Are you getting my point, Shahrukh? More secretory and less proliferative. Less proliferative means, yes, less proliferative means that endometrium thin, on thin endometrium implantation does not occur. Got it? Yes, Shahrukh, very good. Next is mechanism of copper T. You will not forget now any mechanism. Let us do the mechanism of copper T. It's a foreign body reaction, because it is foreign body reaction. Because copper T is a foreign body, so a uterus contracts in order to expel that copper T, so implantation is not possible. So the implantation is not possible. Okay, and copper makes the environment, creates aseptic inflammation. Copper creates aseptic inflammation, and due to both of this factor, implantation is not possible. Okay. Now let's go to the next slide. What are the other benefits of combined oral contraceptive pill? As combined oral contraceptive pill, we already studied. We already studied in combined oral contraceptive pills, the estrogen is very less as compared to the natural estrogen produced in our body, right? So if a patient is having increased estrogenic conditions, the patient will get benefited, right? What are the cancers which are produced, which are in our body due to the increased estrogenic cancers? What are the estrogenic cancers which occur in a female body? Which occur in female body? They are CA ovary. More will be the estrogen. More ova will ovulate. Right? Yes, Shahrukh, you are right. We are coming on that point. So, what are the cancer? First, let's clear cancers. Lot of questions are asked on cancers. So, we will clear it here only. What are the cancers which increase, which are due to, yes, very good, ISRO. Just please write down about cancers. CA ovary, CA endometrium. Both of the chances of these cancers decreases because of the less estrogen in COCPs. Okay, both of these conditions it is protective, but ideally, logically, the CA breast should be protected, but it is not protected. There is no good effect, no bad effect on CA breast. Okay, this is on the basis of clinical trial. Okay, from 2011 onwards, this come in our books. First it was, no, it's right, ISRO. CA ovary, chances of CA ovary decreases because when a patient takes pills, ovulation decreases. CA ovary chances decreases. It is 101% correct. Okay, ISRO? And it is quite often asked, all of these are risk factor for CA ovary except, and in between that it is written OCP pills. So you should know that OCP pills does not increase CA ovary, CA endometrium chances, rather it decreases. Okay, it decreases the chances of CA ovary and CA endometrium, and it has no good, no bad effect on CA breast. Okay, what are the estrogenic conditions, other benign diseases? Fibroadenosis, ovarian cyst, menorrhagia. Why menorrhagia? Because endometrium does not proliferate more, right? DUB, PCOS, metorrhagia. Okay, all these conditions they get correct. Now it also released dysmenorrhea and Mitchell-Schmerz. Why Mitchell-Schmerz is also corrected? Because dysmenorrhea and Mitchell-Schmerz they are related with ovulation. No ovulation, no dysmenorrhea, no Mitchell-Schmerz. Okay, and because no pregnancy occurs, so ectopic is prevented. In the seventh, last is acne. In the last is acne. Okay. Very good. Let's go to the next slide now. What are the conditions? What are the ideal conditions where we can put copper T and combined oral contraceptive pills. Okay, so copper T is not preferred in the case of newly married female. Okay, it is only preferred after one child. Are you getting it? After one child, right? Copper T is not preferred in the case of mm, sorry, copper T is preferred in if the female is not motivated. What do you mean by not motivated? Not motivated means one who cannot remember it to take daily. ठीक है, one lady is there who cannot remember to take the pill daily. So what the ideal thing is to put the copper T inserted, because the labor class people, these people are not have such a motivation to take the pill daily, right? So they have a thought that we don't want pregnancy. Okay, so but they don't have such a motivation, high motivation, that they take that oral pills daily. Okay, so they are not that literate. So we will insert copper T in that patient, because once inserted it works for 10 years it works. Do you get, champ, what I mean by not motivated? Matlab not enough motivation. Yes, of course we will insert copper T only if a patient is ready to insert. We cannot insert copper T by force. It will be done by the patient permission only. But if the patient is not enough motivated, then we will choose copper T instead of combined oral contraceptive pill. Agree? Champ, agree with me? Okay, don't not talking about labor class. Even if we talk about the working females, they don't want to remember and take the things daily. Okay, copper T is long acting, and combined oral contraceptive pill is to be taken daily. So if a patient wants long acting intentionally, ठीक है, a working female who wants it for a long acting, why not for newly married copper T? It is not contraindicated, but a newly married female will not let copper T inserted into its uterus. The newly married females are highly uh, not compliant. It is not a contraindication. We haven't studied contraindication of copper T newly married. We can insert, but usually newly married female is not ready to get insert to a procedure. Yes, you can say risk for PID, but still uh, we can use combined oral contraceptive pills. They are relatively best. Okay, contraindication of all the conditions where combined oral contraceptive pills were contraindicated, they are ideal for copper T. Okay, now you tell me, thread problem. Yes, there are many things, but major thing is that a newly married female don't want a procedure to be done. Okay, contraindication of all the conditions where combined oral contraceptive pill was contraindicated, that where endothelial damage occurs, the conditions where stasis occurs, the condition where the the condition where stasis occurs, the condition where the hypercoagulability is there, lactation condition, liver active diseases, in the diabetes mellitus with vasculopathy, both are contraindicated, copper T and COCP. Please write down what is the contraception of choice in. Please write down what is the contraception of choice in. Write down what is the contraception of choice in diabetes mellitus with vasculopathy. A patient is having diabetes mellitus with vasculopathy. What is the contraception of choice? Yes, it's right. The contraception of choice is barrier method. Okay. Similarly, what all were the contraindications of copper T? What all were the contraindication of copper T? What are the, yes, it's right. Progesterone progesterone pills are not given. POPs are not given in diabetes mellitus with vasculopathy. Again, they are steroidal. Best is barrier. Okay, please correct ISRO. ISRA, please correct. Shahrukh, please correct. POPs are not choice. Barriers are choice. Okay. Then, in what all condition the copper T was contraindicated? Can you tell me what were the indications of contraindications of copper T? Please write down the mnemonic. Please write down the mnemonic contraindication of copper T. Only mnemonic this time. India top ABCD. Yes, it's very right. So, except D, all are the suitable condition for COCPs. Okay, pelvic infections, in the puerperal sepsis, in the anomalies, in the undiagnosed vaginal bleeding, in the A, B, C was cancers. COCP is the choice, right? Got it? Okay. Then copper T is ideal, as copper T is ideal post placental, just after the cesarean or normal delivery and post abortal. Okay, post abortal. Estrogenic conditions, estrogenic diseases, and CA, except CA breast. In all the estrogenic diseases and the dysmenorrhea, COCP becomes choice. Okay, now I think you are very thorough with this table. Now let's start with the another important topic, missed pill. Okay, first you tell me ki when we can start the combined oral contraceptive pills. Please write down in the chat box. A patient came to you. When will you start combined oral contraceptive pill? A newly married female come to you. When you will start combined oral contraceptive pill? Write down in the chat box. These all are expected questions. As soon as possible. Any other answer? Shahrukh has written as soon as possible. Any other answer? After exclusion of pregnancy, but at what period of its LMP? ISRA just want to know which period of its LMP. After exclusion of pregnancy is for every contraception. Okay. At what day of LMP will you advise the patient to start the combined oral contraceptive pill? In the first 5 days. Okay. In the first 5 days. So here I would like to tell you that if property is started on the first 5 days, then the contraception effect comes immediate. If the property if the combined oral contraceptive pill is started on the first 5 days, then the contraception effect from in the first 5 days, then the contraception effects comes immediate. Okay, on any day of the first 5 days of the LMP, if the combined oral contraceptive pill is started, then the contraception effect comes immediate. What if it is not started? For example, a client come to you on day 8, then how much time it takes for the contraception effect to come? Now this time it will not be immediate, but it will take time. How much time will it take to build that contraception effect? Write down in the chat box if you know it. How much days it take? Okay, it takes 7 days. It takes 7 days. Okay, if a patient had started on the 7th day, then contraception effect will come on 14th day. Contraception effect will come, but it will come after 7 days. After 7 days. Okay? Okay? Till 7 days. No, Isaac, it is not 2 days, it is 7 days. Please clear your concept. 2 days for something else. Okay? Contraception effect comes in 7 days. If not started, it on first 5 days, then the contraception effect comes in 7 days. Okay? And if a patient was taking contraception pills and the patient forgets, then the contraception effect goes in 2 days. Contraception effect 0 हो जाता है अगर 2 दिन वो भूल गया है लेना. ठीक है? A client was taking the pills and now the client stopped taking the pills. After how many days the contraception effect will get 0? Now this time it is not 7 days, it is 2 days. Okay, got it? Everyone got it? Contraception effect comes in 7 days. Contraception effect, if a patient is taking pills, goes in 2 days. Okay. Now what will happen if a patient who was taking the pills regularly miss the pill for one pill is missed? For example, I was taking combined oral contraceptive pill. Yesterday I take it at 8 a.m. in the morning. Today 8 a.m. I missed. Will there any effect on the contraception? Write down in the chat box. If I miss one pill, then will there be any effect on the contraception? Write down in the chat box. Yes, no, Shahrukh. No 2 pills, no 2 pills. Now only we studied that there will be no effect. Answer to it is that no 2 pills. First of all, clear this thing. 2 pills means 2 times estrogen. 2 times estrogen means increase vomiting. As there is no contraception loss, so just take the next pill. As I told you, I had taken the pill morning yesterday 8 a.m. So if I remember it tomorrow also, then also no problem. More than 24 hours, 24 to 48 hours, just take the next pill as soon as possible. Shahrukh, no two pills. Okay? Only one pill as soon as possible. Okay? Now, what will happen if a patient miss 2 days? Now the contraception effect will go or not? Okay, you then deal as per options. If in the option it is given as soon as possible, Shahrukh, take next pill as soon as possible, then do take. But always prefer two pills wala option least. Okay? Two pills wala option always prefer least. If in the option only it is written take two pills, then you can mark it correct. Okay? Okay, now if I miss the pills for more than for 2 days or more than 2 days, 2, 3, 4, 5, 6. Okay, now will the contraception effect go? Yes, your answer is effect gone. Yes, very good. Effect gone. ठीक है? Right? Now after 2 days I remembered कि I miss my two pills. Now you tell me how many days it will take to build up the new contraception effect. Contraception effect has gone. Now I have to build new contraception effect. How much days it will take? How much days it will take? Please answer. Please answer how much days it will take. Now if I start taking the pills again, I will not take two pills because two pills cause vomiting. You tell me 7 days. Yes, ISRO 7 days. For 7 days I have one has to use another method. Got it? For 7 days the client has to use another method of contraception. Okay? And in this condition also take one pill as soon as possible plus 7 days other method you have to use. Okay, got it? Next, something more we have to do. Okay, something more we have to do. Now, how these pills are prescribed? How these pills are prescribed? These pills are prescribed. We give the patient on say first LMP first day we give. Okay. Then what we will do? Patient will take it for 3 weeks. Then 1 week it will be off. Then the patient again will take for 3 weeks. Then 1 week it will be off. This is a general prescription of OCP pills. Okay, general prescription of OCP pills. 3 weeks take, then 1 week off, then 3 weeks, then 1 week off. In that 1 week periods occur. Okay. Now if more than 2 pills are missed in first week, if more than 2 pills are missed in first week, then what one can do? One has to take emergency contraception. LMP जब स्टार्ट की थी पिल उसके फर्स्ट वीक में ही 2 बार मिस हो गया, 2 से ज्यादा बार मिस हो गया. ठीक है. देन emergency contraception, everything this has been done already. Okay, so emergency contraception is done. Emergency contraception is taken. Got it? In second week, nothing additional has to be done. So one client has to consider emergency contraception pill if more than 2 pills are missed in first week. If more than 2 pills are missed in second week, then nothing to be done extra than those 2 things we read in the last slide. Okay. If the combined oral contraceptive pills are missed more than 2 or 2, then in the third week, then one has to omit the pill-free period. So this is the pill free period. this इसको पिल फ्री नहीं रहने देंगे, इसमें भी पिल्स खाएंगे, कंबाइंड ओरल कॉन्ट्रासेप्टिव पिल्स इसमें भी खाएंगे. One has to take the pills in this off week also. That is what meaning of the omit the pill free period. Got it? Got it? You will now tell me fastly why we have given emergency contraception in the first week. In addition to the barrier contraceptive pill, why we have given the emergency contraception in the first week? Because the critical growing of, I will tell you in 1-2 lines, okay, either you ratify this or either you understand in this one line, okay, because in the contraception effect is not there. If the pill is missed in first week, then the more than 2 pills or 2 or more than 2 pills are missed in first week, then the pill, the contraception free period is the second week, and that is very important for the ova to grow. If the ova will grow, then it can fertilize at 14th day after second week. That is why. Okay, ISRO, that is for that is in third, that is for third week. If it is missed in the third week, then we will omit the pill free period because it will take 7 days to build up. Okay, ठीक है, that's why. Let's go to the next slide. Yes, you are right, Shahrukh, you are right. Okay, mixed copper T. Now let's go to the mixed copper T. Yes, you are right, Shahrukh. High chances of fertilization are there in the second week, which was the contraception free week. Okay, let's go to the mixed copper T thread. Now if copper T thread is missing, then there can be 3 conditions. Either the copper T has expelled out, either the copper T is inside the uterus, or the copper T has perforated the uterus and gone into the peritoneal cavity. Okay, no concepts, you all of you know this, I'm just revising it. We will out all these 3 conditions. Out of this, what is the 3 what condition is your patient suffering from, that will be diagnosed on TVS and per abdomen ultrasound. Okay, TVS and per abdomen ultrasound. Okay, right? Agar copper T thread is not there, then 3 conditions can be there. Either the copper T has expelled out, or the copper T is in the uterus and thread has broken, or the copper T has gone on other than uterus after perforating it, right? Most commonly in the check thread by finger. Yes, it is missed copper T thread once the doctor has checked. Okay, patient has come to you with missing copper T thread. First doctor has checked and now also the thread is missing. Now what can be the 3 conditions? Either the copper T has expelled out of the uterus, or it is inside the uterus and thread is broken, or the copper T has perforated the uterus and gone into the peritoneal cavity. Out of these 3 conditions, which condition is there will be diagnosed by TVS and per abdomen ultrasound. Okay, if the copper T has expelled out, then no worries, right? Just get another copper T inserted. If the copper T is inside the uterus, then remove it with copper T hook. If it is not possible to remove it with copper T hook, then remove it by hysteroscopy. Okay, if the copper T has perforated into the peritoneal cavity, has gone into the peritoneal cavity, then the best choice is laparoscopy. If by with the help of laparoscopy one cannot do, then laparotomy. This is the procedure of choice. Okay, yes. Now the another condition on which the question is asked, pregnancy with copper T. If copper T failed, copper T is inside the uterus and pregnancy has occurred, then the chances of abortion are 50%. The chances of abortion are 50%, right? Chances of abortion are 50%. Whether or not the patient will continue the pregnancy or take the decision of MTP depends on the. Shahrukh, you are telling ectopic pregnancy. No, it's confirmed, it's intrauterine. Ectopic pregnancies do occur, but rarely they occur. More commonly, intrauterine pregnancy occurs. Okay. Yes, chances of ectopic are there, but they are rare. Then more common is intrauterine pregnancies. Okay. So if it is not written ectopic, then you need not to think about ectopic. More common is intrauterine. So you will think of common things first. Okay. So whether the patient has to continue after clearing that it is intrauterine or ectopic, then if it is intrauterine, then the decision to continue or not depends on the patient, because equal chances of failure are there and equal chances of survival are there. As I told you, 50% 50-50 chances है. सर्वाइव होने की भी 50 है और ना सर्वाइव होने की भी 50 है. Got it? Have you got it? Okay. Now the copper T is inside and pregnancy has occurred. Whether you will remove copper T or not, copper T will be removed only if it is very easy to remove it. Okay? Or it will be only removed if the threat is palpable. If the threat is palpable. Okay? If the threat is palpable at os. If the threat is palpable at os, then only you will remove copper T. अगर thread अंदर कहीं ऊपर है, fundus पे है, if the thread is at the fundus, then you are not going to remove the copper T. You will continue the pregnancy. Is it okay? Okay. Now let's start with one-liners of copper T. When it is written copper T 380A, what does this A means? And what does this 380 means? What does this A mean? And what does this 380 means? 380 means copper area in millimeter square. And A means arms. A means arms, in which these are the arms of T. These are the arms of T. If the copper is present on arms, then we will write it A at the last. Okay? Yes, very good, very good. Most common complication of copper T IUCD is? Most common complication of copper T IUCD is bleeding. Second most common complication is pain. Okay. Most common complication of copper T IUCD is bleeding. Second most common complication is pain. The most common reason for the removal of copper T is pain. Yes, most common reason for the removal of copper T is pain. Got it? Copper T has to be checked by the lady every month after the menses by feeling the thread with one finger in the vagina. Okay? Okay? Next line. Next slide. When can be the copper T inserted? And what is the second most common cause of copper T removal? First most common cause of copper T removal is pain. Second most common cause of copper T removal is Isaac, are you there? You are not active. What is the second most common cause of copper T removal? A patient wants to get the copper T removed. First most common cause is pain. The second most common cause is, please write down, PID. No, it's bleeding. Okay, it's bleeding. Okay. First most common side effect is bleeding. Second most common side effect is pain. Most common reason for the removal of the copper T is pain. Second most common reason is menorrhagia, increased bleeding. Got it? Okay. Then next is in menstrual period. Yes, very good. When is the copper T inserted? In a non-pregnant lady, when is the copper T inserted? Within the first 10 days. In non-pregnant. In non-pregnant, it is inserted within the first 10 days. Okay. When is the copper T inserted? After the delivery. Write down in the chat box. Today delivery occurred at 5 p.m. Up till how much time one can get the copper T done? Write down please in the chat box. No, not after 42 days. Within first 48 hours, one can get the copper T insert. Within first 48 hours, copper T can be inserted. Yes, immediately or within the first 48 hours. No need to wait for 42 days to complete. Okay, first 48 hours one can insert. Is it clear to you, Isaac? So it is not after 10 minutes. It is just after the placenta removal. Up till 48 hours we can insert. Are you clear with these things? After that 48 hours, we will insert the copper T after 6 weeks. Clear to all of you? Clear to all of you? What is the name of the time given if the copper T is inserted after 6 weeks? After 6 weeks, if the copper T is inserted, what is that known as? Interval copper T. Need not to go Isra in such a deep. Need not to go in such a deep. Okay? It's too deep, need not to go. After 10 needs applicator. No, it is not needed after 10 minutes. It's not needed. Applicator is not needed. Okay? It is immunosuppression. I didn't get you. Immunosuppression. And so here I would like to tell you that copper T is and if inserted after 6 weeks, it is known as interval copper T insertion. Okay, and post abortion, it is the method of choice. Okay. What is the name of this property? What is the name of this property? I'm not getting you, Shahrukh. Please write in detail. What is the name of this property? This is number one. This is number two. This is number three. Write down the names in the chat box. Name of the property. Write down. Yes, Isaac, it's right. It's 200. Any other name? Which is 380? Which is 380 medicine? Which is 380? 1, 2 or 3? Please write down the names of the three property I have shown you here. I'm showing you here in the 3 is multi-load. Very good. Isra, 3 is multi-load. These serrated edges are so that property does not get expelled. What is the name of one property? 200 is okay. It can be any property except 380A and Nova T. Okay. It can be any. Number one is any property except 380A and Nova and multi-load. Okay. And multi-load. Yes. Medicine, you are right. It is 380A. Okay. And number 3 is multi-load. Yes, all of you are right. So property and combined oral contraceptive pills are completed. Let's go to the next topic. Progesterone only contraception. Do attempt this. Do attempt this question. Shahrukh, third one property was multi-load. Okay. No, Isro, it's okay. It's okay. I have no rest needed. We will just finish the topic. Okay. Okay, it's hardly 1 hour. Are you able to see the question? Are you able to see the question? Write the answer. Write the answer in chat box. Now we will be doing only progesterone, only contraception. The contraception which contains only progesterone. Write down the answer. No, Isaac, read the question carefully. No, 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 read the Shahrukh, you are right. 20 microgram. Total progesterone in the Mirena is is 52 mg, and progesterone which is released in the Mirena is released per day is 20 microgram. Okay, very less chances are there that this question will be asked. I just want to tell you the another name of the Mirena is levonorgestrel 20, because it releases progesterone 20 mcg daily. Okay, let's start with progesterone only contraception. Progesterone only contraception, what is basically its mechanism of action? Here I would like to ask you, what is the action of progesterone on endometrium? Write down in the chat box, what is the action of progesterone on the endometrium? Don't read from here, it is not written. What is the action of progesterone on the endometrium? It makes the endometrium secretory. One more function. Other than this action, what is the another action? What is the another action other than this? Stabilize. What do you mean by stabilize medicine? Can you tell me? What do you mean by stabilize? For example, if this was the endometrium, estrogen increases the endometrium, grows the endometrium. Progesterone stops its growth. Stabilization का मतलब होता है, stabilization means stopping its growth. Okay, stopping the growth of endometrium, वहीं पे ही रोक देना. Stopping the growth of the endometrium. Is it okay? Okay. Now what will happen if we give the progesterone from the day 1 itself? What will happen if we are giving the progesterone? In progesterone only pills, we give the progesterone from day 1 itself. What will happen? Endometrium will not grow. Endometrium will be thin. Okay? Endometrium will be thin. It will be not suitable for implantation. It will not be suitable for implantation. Right? And the another mechanism is no ovulation. Okay? Don't forget this mechanism, that endometrium will not proliferate. If the endometrium was proliferating up till 10 mm, now after giving progesterone from day 1, the endometrium will proliferate only 1 or 2. On such a thin endometrium, it is very difficult for the embryo to implant. Moreover, ovulation will not occur. Now you tell me, if the endometrium will thin, then menorrhagia will cured or not? Type in the chat box, menorrhagia will be cured or not. Menorrhagia will be cured or not. Yes, Shahrukh, you are right. Shedding of endometrium is caused by progesterone withdrawal, not by progesterone. Okay? We are coming on that point. Shahrukh, we are coming on that point. Now you tell me, a patient who is taking progesterone only contraceptive pill, will the menorrhagia cured or not? If the patient is having endometrial cancer, what happens in endometrial cancer? Proliferation occurs too much. Will the endometrial cancer chances decrease or not? Decrease or not? Will this progesterone... Menorrhagia is due to increased endometrial proliferation. Menorrhagia is due to increased endometrial proliferation. So, because there is less endometrial proliferation, menorrhagia will be cured. Is it okay? Yes, a lady who is taking progesterone only pills, the chances of endometrial cancers are very less. Okay. Now you tell me that these two good effects, menorrhagia is cured, endometrial cancer chances are less. Now you tell me, why the patients don't take progesterone only pills? Why the patient don't take progesterone only pills? Be fast. Because if these pills are missed for 1 hour, these pills are missed, their contraception effect goes. Such a high compliance is required. Such a high compliance is required. That is why patients are not, it is not patient favorite. Right? In spite of these two advantages, that menorrhagia gets treated and endometrial cancer are very less chances, then also patient don't take mini pill or progesterone only pill, because if this pill gets delayed for 1 hour, failure rate, its effect goes very good. That is why progesterone sustained release preparations has come into the market. Okay, progesterone sustained release. Okay, before I go to the next slide, I want to tell you the effect of all the progesterone only contraception is irregular bleeding. All the progesterone only contraception has a common side effect, irregular bleeding. Okay, and as these progesterone are steroids, so they have to be started after 6 weeks of delivery. 6 weeks of delivery. You cannot start it immediately. Okay, let's move to the next slide. What are its sustained release preparations? Injection depot medroxyprogesterone acetate. Okay, you need not to learn everything. You have to just remember that it contains the progesterone, medroxyprogesterone acetate, right? And it is for 3 months. Next is imiplanon. Imiplanon is for 3 years and it is an implant. It is an implant and it is given subdermally in the arm, and it has the progesterone desogestrel. Okay. Levonorgestrel IUCD, it is an intrauterine contraception device and it is for 5 years and it contains the progesterone levonorgestrel. Do this next question. Preferred mode of contraception in lactation. I think you all know. Without wasting much time, I go to the another, that is the preferred mode of contraception in lactation is progesterone only pills, but it is given after 6 weeks of delivery. It cannot be given immediate. The contraception which can be given immediate is copper T. Now this is the image of Mirena. It contains no copper and this is the image of copper T. Going to the another mode of method, sterilization. All of you know that vasectomy, the latest technique is non-scalpel vasectomy, and the main disadvantage of vasectomy is that sterility is not immediate. Because the part of the vas deferens which is distal to the blockage, it also has sperms, right? The part of the vas deferens which is distal to the blockage, it also has sperms and it takes 3 months to empty that. Okay? Okay. Shahrukh, I'm not getting you. Please. Please write down again. I'm not getting you what you want to say. 6 weeks तक barriers use करेंगे. Yes. कॉपर टी 6 वीक्स तक यूज कर सकते हैं. ओके. ट्यूबेक्टमी इज the ligating the female fallopian tubes and cutting it. Usually isthmus is ligated. No beta, it is not 6 months, it is 3 months. Yes, I know, as I know that you all of you know that is why I'm going fast. Okay, I'm not staying here on this topic. I know you all of you know this. Okay, let us complete fast the topics which you were lagging behind. We have already been gone slow. Okay, usually isthmus of the fallopian tube is ligated as the chances of recanalization is maximum. We can ligate the tube either by approaching the peritoneum by laparotomy or laparoscopy. If we do laparotomy, then the procedure is known as mini lap. Mini lap means laparotomy. Laparotomy which has very small incision. Okay. Laparoscopic procedures, they cannot be done postpartum. Okay, they cannot be done postpartum. Mini lap can be done postpartum up till 7 days, because up till 7 days uterus is not a pelvic organ. After 7 to 10 days uterus becomes a pelvic organ, then even mini lap cannot be done. Okay, most common technique for mini lap is Pomeroy technique. What is done in modified Pomeroy technique is that we hold the fallopian tube with Babcock's forceps. This Babcock forceps can come in your exam. Okay, we hold the fallopian tube with Babcock forceps, then we tie the fallopian tube with the suture. Okay, then we cut the fallopian tube, right? And then we leave it as such. Okay, we have not embedded here, not embedded here. We leave it as such. This was a question in NEET PG20. What is this instrument used for? Here I would like to tell you that all those instruments which have like this circles, rings here, these are laparoscopic instruments. Okay, which have long tubes and circles at the last. These are the laparoscopic instruments. And you can see here it has this prongs at the end. These prongs are to catch the fallopian tube, just as the Babcock's forceps was doing. Okay, Shahrukh, we will discuss it. All of you can write down in the chat box which topic you want tomorrow. Urogyne will be completed today itself. Urogyne will be completed today itself. You can write down in the chat box what all topic you want tomorrow 4 p.m. Okay. So these prongs catch the fallopian tube, and you can see here, if you will zoom your camera, that here there are rings. I have made them red. Okay. These rings then go onto the fallopian tube and ligate it. Okay. Got it? So answer to this question is lab sterilization. Okay. Next is non-scalpel vasectomy. The false is sterility immediately. Okay, done. Purpurium done. Tomorrow topic suggestion has come for purpurium, done. Not used as emergency contraception. Now let's do emergency contraception. It is again one of the most important topic in contraception. Just focus here for 1 minute. You will know the concept of contraception. In the process of fertilization, there are two main steps: coitus and implantation. Okay, in the process of formation of baby, there are two main steps. Two main steps are there: coitus and implantation. If a method is taken before the coitus, that method is known as contraception. If you take a method to stop the pregnancy before the coitus, then that method is known as contraception. If a method is taken to stop the pregnancy after the coitus and before the implantation, then that method is known as emergency contraception. Now, can you tell me what is the time period between these two activities, between the coitus and implantation? What is the time period? Or you can tell me what is the time period between the fertilization and implantation? Anyone? After how many days of fertilization implantation occurs? Please be fast. It is 7 to 9 days. Isaac, it is 7 to 9 days. Okay. So what all? Because yes, it's right. 7 to 9 days. After fertilization, it takes 7 to 9 days. Yes, right. So again, I am telling you here that we whatever drug which we want to give for emergency contraception, that is after coitus, should act within 6 days. Should act within 6 days. And that is why in the emergency contraception we give very high doses. Okay. What is abortion? The drugs which are used after abortion are, after implantation, are abortifacient. What are abortifacient? Mifepristone, misoprost, MTP drugs. Once implantation has occurred, then we will use abortifacients. If coitus has occurred, implantation has not occurred, then we will use the emergency contraception. Before coitus is contraception. There are total 6 methods in India. Okay. Number 1 is the I pill or unwanted 72 pill. Morning after pills. Yes, Shahrukh, you are right. Abortifacient are Mifi and Miso. I pill, the another name is 70 unwanted 72, and the another name is morning after pill. Morning after pill. The drug which it contains is, all of you know, levonorgestrel. Mechanism of action is it inhibits ovulation, implantation, and tubal motility. Common mechanism of action of all the emergency contraceptions is inhibits implantation. Okay. High dose progesterone is this. This is high dose progesterone. The dose is 1.5 mg. You have to learn. It is given within 72 hours of the unprotected intercourse. It is available over the counter. What do you mean by available over the counter? It means doctor prescription is not required. Okay, doctor prescription is not required. Medical shop वाला बिना doctor prescription के ये drug दे देगा. The another drug which can be used is high dose estrogen, but it is not used because increased dose of estrogen leads to increased vomiting. But it can act as emergency contraception. High dose progesterone is the method of choice, and high dose estrogen is the least method of choice because estrogen causes vomiting. Third method is UGP regimen. UGP told that sometimes the patients don't have money to buy the I pill. In that case, yes, Ishaq, one can get it over the counter without the prescription. That government has made it over the counter drug. Okay. UGP regimen, Dr. UGP said that sometimes patient does not have money. So can we use our normal routine estrogen progesterone pills for contraception? Yes, we can use. Okay. So at that time when UGP suggested to took, that time combined oral contraceptive pills contain 50 microgram ethinyl estradiol and 250 mics of the progesterone. But these days this is very less in amount. So if one has to take combined oral contraceptive pills today, then 4 pills in the morning and after 12 hours 4 pills. Total of 8 pills. Okay. Total of 8 pill. The fourth drug which can be used within 72 hours is mifepristone. It is basically an anti-progestin. It inhibits implantation. Its dose is 10 to 50 mg. A lot of confusion was there for the dose. Its dose is 10 to 50 mg. Okay, 600 mg was the only dose available before, but these days 10 mg, 25 mg, 50 mg are available. All doses can act. Okay, so your choice in the option should be 10 mg, then 600 mg. Okay, got it? Yes, Shahrukh, drug of choice is levonorgestrel. So this mifepristone acts up till 72 hours of unprotected intercourse. It is not available in India. Okay, it is available in India only for abortifacients. Going to the next drug, it is the ulipristal. Ulipristal is a selective progesterone receptor modulator. Selective estrogen receptor modulator बहुत सारे हैं, but selective progesterone receptor modulator is only one, ulipristal. Okay, ulipristal dose is 30 mg. Already question has come in the exam. Okay, and this is not available in India, and it can be used for 5 days after the unprotected intercourse. You have to remember this 30 mg and 5 days for ulipristal. Okay, copper T E can also be used for 5 days, and it is freely available. Now let us talk about Pearl's index. Pearl's index means that if 100 women were using a method of contraception for a year, 100 women were using a method of contraception for 1 year, then how many women will conceive? How many women will conceive? That is Pearl index. In other words, Pearl index is failure of contraception per 100 women year. Okay, the least failure is of implant imiplanon. What is the Pearl index of imiplanon? It is less than tubectomy and vasectomy both. Okay, tubectomy and vasectomy दोनों से कम है, ऑपरेशन से भी ज्यादा असरदार है इम्प्लांट. Again I am telling you, it's highly expected question. Pearl index is lowest in. This is the highly expected question. Okay. Please write down in the chat box. Pearl index is lowest in A, B, C or D. Shahrukh, write down. If you don't know, then please any guesses. No, it is imiplanon. Implant, progesterone implant, imiplanon has the least failure rate. Okay, the correct answer is C. Okay, all of you are watching, please write down in the chat box the least failure rate is of implant, progesterone implant, imiplanon. It is 0.5. It is much, much less than tubectomy and vasectomy. Correct yourself. Correct yourself. Yes. Sorry, it is 0.05. Thank you, Shahrukh. It is 0.05. Okay. It is 0.05. What is the contraception? What is the Pearl's index for tubectomy? For vasectomy, it is 0.1. What is the Pearl's index for tubectomy? It is double, 0.2. It is 0.2. And equal is that of the Mirena. Equal is that of the Mirena. Mirena also has got 0.2. Okay. Copper T and combined oral contraceptive, they have same, almost same, 0.5, 0.6. Okay. Copper T and combined oral contraceptive, they have almost same. Okay. Now you tell me what are LARC. What is LARC? Question has come 3 times and it is again a highly expected question. What is LARC? Long acting reversible contraception. Long acting reversible contraception. What do you mean by reversible? It means it is not permanent. So tubectomies are not in. Tubectomies and vasectomies are not in this LARCs. LARC does not contain tubectomies and vasectomies. Have you got it? It is highly expected question. All of these are LARC except you will always mark tubectomy and vasectomy. Okay. One definition is that the method should be reversible. The another definition is that it should be long acting. So Williams' definition of long acting is that at least once taken, it should act for 1 month. It should act for 1 month. Okay, that is LARC. That is the meaning of long here. Once taken, it should act for 1 month. Okay, so LARC contains copper T, levonorgestrel IUDs, intrauterine devices, implants, injection DMPA. Injection DMPA acts for 3 months. Okay, here I would like to tell you that some vaginal rings come of combined oral contraceptive pills. They work for 1 month. Okay, so those combined oral contraceptive rings, once inserted in the vagina, they act for 1 month. They act for 1 month. They are also LARC. Okay, do you got it? This highly expected question, it has come in November 22 INI set. Okay, let's go to the next slide. What does this contain? This is a barrier contraceptive. Today is a vaginal sponge and it contains permicidal jelly, nanoxynol 9. This is female condom. So barrier methods are given, can be given to both male and female. The male barriers are only condom and the female barriers are many. The female condom trade name is Femidome. Femidome. The trade name of female condom is Femidome. Okay. Then the other than sponge which we studied today, the other barrier methods which a female can use is diaphragm and caps. If they are left in place by the female for more than 24 hours, then they cause septic shock syndrome. Usually all these barriers, they are coated with permicidal jelly, nanoxynol 9. Okay. This is the shape of cervical cap. And the semicircular shape is of the diaphragm. Okay. Have you got it? These are nothing but Femidome is usable. Yes, it is usable. Yes, it is usable. This is the vaginal rings and it contains both estrogen plus progesterone. So these are not barriers. These are combined hormonal contraceptive. Okay, this is patch. ठीक है, maximum they work for 1 month. They can also work less than 1 month. ठीक है, these are not barriers. Okay, these are combined hormonal contraceptive. Okay, clear? Last but not the least is the natural method. It has a high failure rate, right? The safe period is the first 7 days and the last 7 days. Okay, these are also known as billing method, rhythm method and behavioral method. If any problem is there, please write down or I will go to urogynecology. Please write down in the chat box if you have any problem or we will start with urogynecology. Triple S is step for step. I haven't read it from last 1-2 months about it, but I think it is step. Okay, let's start with urogynecology. So what is prolapse? First of all, let's take prolapse. What is prolapse? Here I would like to tell you that prolapse means the uterus has come outside. Uterus had come outside. Okay, usually this is uterus, this is vagina, Usually the uterus does not come out, but when it comes out, it is known as prolapse. Okay, coming out of the uterus, out of the vagina is prolapse. Okay, now it means all those supports which were keeping the uterus there, they have weakened. So let's study what are the supports. The supports are divided into three categories: primary supports, secondary support, and tertiary supports. Okay, supports are categorized into main supports are primary support. Because we are at graduation level, we will study only primary support. Okay, primary support are of three types: uterine axis, muscular support, and ligament support. Out of all of these, muscular support is the most important support. Out of all of these, muscular support is the most important support. Okay, no one of you will write in exam that ligament support is most supportive. Main support, most important is they are not that important. They are not that important. They haven't been asked since last 10 years. They have not been asked. Let's Isaac, let's be focused on our exam. Okay, in the detailed class we will discuss the three tiers and three supports. Okay, now it is not that I am not discussing muscular support first, so muscular support is not important. Most important is muscular support. Yes, Isra, levator and I is the most important support. Okay, now number first we are discussing uterine axis. What you mean by uterine axis? This is uterus, this is cervix, and this is vagina. Okay, this is vagina, right? And if we draw a line going through it, this is uterine axis, this is cervix axis, and this is vagina axis, right? This is vagina axis. The angle between the cervix and the angle between the uterine axis and the cervix is known as angle of anteflexion. Angle of anteflexion, and it is 120 degree. The angle between the vaginal axis and the cervix axis is angle of version, angle of anteversion, and it is 90 degree. Okay, and it is 90 degree. Is it clear to you? Take this question. Already we have studied this thing. Take this question. Angle of anteflexion and anteversion is maintained by. First you write down in the chat box. Anteflexion is maintained by. Highly expected question. Angle of anteflexion is maintained by. First write down in the chat box. Anteflexion is maintained by. Which ligament flex the uterus? यूट्रस को कौन फ्लेक्स करता है? इंटीरियरली. Yes, it is round ligament. Okay, and which ligament maintains version? Which ligaments maintain version? uterosacral. Okay, okay, is it clear to you? Uterosacral maintains anteversion and round ligament maintains anti-flexion. Okay, so you will see here. Yes, yes. See here, round ligament originates from the uterus and then it goes literally up till the pelvic wall. Are you able to appreciate it? And after going to the pelvic wall, it enters the inguinal canal. See, it has entered the inguinal canal and then it get insert into the labia majora anterior part. Okay, this is how is the root. This anterior and forward inclination of the round ligament causes the uterus to flex. Okay, causes the uterus to flex. Now let us see the anatomy of the muscle. Okay, let us see the anatomy of the muscle. This is levator ani. This is the longitudinal section of the levator ani. See my hands now. How is levator ani in the uterus? Imagine this pen as uterus. Levator ani has holded the uterus like this. Are you able to see? Levator ani has holded the uterus like this. Okay, such a strong grip is of the levator ani. Such a strong. Okay, so levator ani hold the okay, so I think it will help you to learn that such a strong grip is of the levator ani. That is why I showed you by uh, presentation. Okay, now this levator ani, it has this is levator ani and this is the urogenital diaphragm. Okay, levator ani is the pelvic diaphragm. Okay, and this is the urogenital diaphragm, and at the last here this is the perineal body. This is the perineal body. Okay, so now you tell me which is the strongest support. Of course it is the levator ani. The other muscular supports are urogenital diaphragm and the perineal body. Okay, okay. Levator ani is made up of three muscles. Okay, there are three bones of pelvis: pubis, ilium, and ischium. So are the name. Okay, Levator ani is made up of three muscles. So you can see this is the muscle of the levator ani, which is starting from pubis, and it is going and inserting in the coccyx. This muscle starts from the pubis muscle and get insert in the coccyx. This is known as pubococcygeus, right? The another muscle, this muscle start from the ilium bone, and again it get inserted into the coccyx. The third is coccygeus. It starts from ischium and get insert into the coccyx. So they can ask you, levator ani is made up of which three muscle? It is made up of pubococcygeus, is iliococcygeus and ischio-coccygeus. Okay. Now let's talk about the ligament support. At the cervix, now this is a transverse section. This is pubic symphysis. Anterior part, this is the pubic bone or pubic symphysis. And this is sacrum. This structure is the bladder. This is cervix. And this is rectum. All of you know that bladder is anteriorly, then comes the cervix, then comes the rectum, right? One pair of fibers, they start from the cervix and they get inserted on the pubic bone. They are known as pubocervical ligament. Pubocervical ligament. Another pair of the ligaments start from cervix and they spread transversely. They are known as transverse cervical ligament. Okay. The another third pair start from cervix and get insert posteriorly to the sacrum. They are known as uterosacral. Uterosacral. Okay. They are known as uterosacral. So these are the three ligaments. Out of these, the transverse cervical is the main. It is also known as Mackenrod's ligament or the cardinal ligament. These three ligaments together they form the triradiate ligament. Triradiate, तीन डायरेक्शंस में जा रहे हैं, रेडियली जा रहे हैं, तो they are known as triradiate ligament. Okay. Let's now discuss prolapse. Supports, do you have any query? If you have any query, then write down in the chat box. Now let's discuss prolapse. What happens in prolapse? This uterus, it comes down. It comes down because the levator ani, which is the main support, it weakens. Which was holding the uterus, it has weakened. Okay. Now when this uterus comes down, not only this uterus comes down, these vaginal walls, they also come down. See, you can see in the diagram that the vaginal walls, they also come down. Right? And the structures which are related to it. Yes, Isra, Mackenrod's ligament is equal to transverse cervical is equals to cardinal. ठीक है? Okay? Is it okay? So now when the uterus comes down, the vaginal wall also come down. So comes down if the bladder and the rectum. Okay, when the bladder comes down, it is known as cystocele, and when the rectum comes down, it is known as rectocele. It is known as rectocele. Okay, have you got it? What is the etiology of prolapse? As we studied, the most important support is levator ani. All that which will weak the levator ani will weak the uh, uterus supports and prolapse will occur. The levator ani has two type of tone, estrogen tone and the normal neural tone. नर्व्स भी सप्लाई करती हैं और जो है ईस्ट्रोजन की वजह से भी वो टोन में रहती है मसल, नर्व्स की वजह से भी रहती है टोन में. ओके, सो नर्व्स की वजह से भी टोन में रहती है लिवेटर एनाई. व्हेन डज ईस्ट्रोजन गोज आउट ऑफ द बॉडी ऑफ अ फीमेल? एट menopause. At menopause. And when does nerves goes? With age. As the levator ani will work, more the levator ani will work, more the levator ani will weak. Okay, all the factors which will stretch the levator ani will weak the uterus support. Okay, when a lady is pregnant, the uterus becomes such a large and it contains much weight. So always a Paris lady will be much Paris lady parity. The pregnant lady will have weak levator ani because the whole 9 month levator ani ने ही तो उठाया था बच्चे को, राइट. लिवेटर एनआई वीक हो जाएगी ना, 9 महीना बच्चा उठाती रही, right. And during the labor pains also, the all the contractions which occur are beared by the levator ani. So more is the lady pregnant, more is the lady paras, more is the lady levator ani gets weak, more is the lady goes through normal deliveries, more is the levator ani gets weak. Okay, so menopause, labor pains, parity, all these conditions, they increase the levator ani weakness. The things which you make it wrong, that forceps and perineal tear, they also prone the patient for prolapse. No, they will not prone the patient to prolapse because they cut short the second stage. They will help the patient. They will help the patient and decrease the risk. Anything which will cut short the labor pain. If a patient, antenatal patient goes through cesarean, then chances of it to go into prolapse is much less than the patient who has gone through normal vaginal delivery. Okay, have you got it? Okay, now let's see if anterior two-third of the vaginal wall, this anterior two-third of the vaginal wall, it comes down. If this wall comes down, then it is known as cystocele, because in the upper two-third of the vaginal wall, what is in relation? Bladder is in relation, right? And in the lower one-third, what is in relation? If lower one-third vaginal wall will come down, then what else will come with it? Urethra will come, lower anterior one-third. Then urethra will come along with the vaginal wall. Right? They are not separate, they are stick to each other. And in the case of posterior vaginal wall, if upper one-third will come, then intestine will come, large intestine will come, then it will known as enterocele. If middle one-third of vaginal wall, posterior vaginal wall gets prolapsed, then it will be rectocele. And if lower one-third vaginal wall gets prolapsed, then it will be, yes, lax perineum. Lax perineum. Okay, you can appreciate all of these things with the help of this diagram. Okay, have you got it? Have you got it? What is the treatment of cystocele? What is the treatment of cystocele? Treatments we will discuss later. Let's discuss Shaw's classification. Okay. Shaw's scientists have classified the prolapse depending on the position of introitus of the cervix in relation to introitus. First stage of prolapse is cervix is inside the vagina. When the cervix is above the introitus, it is first stage. Yes, it's right, Isaac. We will discuss this later. Okay. The second stage, when the cervix is at the level of introitus. Third stage is when the cervix has come out of the introitus. Then fourth stage is when fundus is also outside the introitus. As you can see here, if the cervix is here inside the vagina, uterus has prolapsed and cervix is above the introitus, then it is first degree, right? And if the cervix is at the level of introitus, then it is second degree. What if this cervix is outside the introitus? Then it is third degree. And if the fundus is outside the introitus, like this, then it is fourth degree or procedentia. Okay. As you can see that in the Shaw's classification, We only know how much the uterus has come down. We don't know what is happening with cystocele, whether erythrocele is there or not, whether rectocele is there or not. We don't know about all such things. So, a new classification was invented, discovered, POPQ. POPQ, where POP means pelvic organ prolapse, Q means quantification. Q stands for quantification. Okay, now this is the classification which is universally accepted. You just need only to learn its name. Okay, you just need only to learn its name. Okay, it has, and you need to learn two more things. It has 9 points where we do measurements. How many points are there to do measurements in POPQ? There are 9 points. You will write down in the chat box that there are 9 points. Okay, not only the POPQ classification helps to quantify the prolapse, it also helps to quantify whether the operation done for the prolapse is how much successful. Is it 100% successful, 90% successful, how much successful? So it also helps to quantify the outcome. It also helps to quantify the outcome. Only these things you have to learn. POPQ classification is universally accepted, and it helps to quantify each and every prolapse. It has 9 points of measurement, and it also helps to quantify the outcome. Let us study now decubitus ulcer. Please take this question. Please take this question. Yes, answer to this is packing. What is the etiology of decubitus ulcer? What is the, yes, answer is packing. Okay, what is the, not answer Shahrukh, it's not cryotherapy. Now you will learn why it is not cryotherapy. Okay, let me tell you. This is vagina, right? And this is cervix. Just to show you, I have made a very long vagina, broad vagina. Okay, just to explain you, right? Just to explain you, I have made such a broad vagina. Okay, now when the uterus prolapse, not only the uterus prolapse, large number of the tissues, the ligaments which are here, the veins, the blood supplies which are here, they also come down. They also come down. Okay, now we are only concerned with decubitus ulcer. So we are making only the veins. So these veins, they also come down. The veins which were supplying the uterus, they also come down. Right? They also come down. As you know that the vagina is very narrow as compared to the peritoneum. Right? The vagina is very narrow as compared to the peritoneum. So these veins in this narrow vagina, they undergo congestion, venous congestion. And due to that congestion, ulcers are formed in the lower part of the uterus due to the decreased blood supply. Due to the decreased blood supply, uh, the ulcers are formed. Right? Do you get it? Now, will you write the correct etiology in exam? The etiology of decubitus ulcer is venous congestion in the of the venous congestion of the veins in the prolapse uterus. Right? So first, its treatment is repositioning. You have to take this uterus and put it in the exact position manually. Right? Manually. Have you got it? Manually you have to do it. Then, as you know, supports are weak. Again it will come down. To stop the again coming down of that prolapse uterus, you will take the help of pessary or packing. Okay? Pessary or packing. So Shahrukh, it is right now. So what will be the answer to this question? It will be packing, but after manual repositioning. Okay, usually these packings and manual repositionings, these are the job of interns or first year residents. That is why they ask you lot about decubitus ulcer. Decubitus ulcer etiology is never friction. Etiology is venous congestion. Okay. Now let us study the treatment of prolapse. Okay. If the family is not completed, I think all of you were in the yesterday's class. Do you want me to discuss this prolapse treatment again? Already we have discussed yesterday. Please type in the chat box. It will save over time. We can focus more on fistulas and incontinence. We have discussed all this treatment yesterday in the after the quiz. Do you want me to discuss it again, or is it okay that I leave this topic and go on fistulas or pessary, which are the more important topics? Please write down in the chat box, can I leave this topic? Treatment already we have done yesterday. Okay, I am leaving it. If any one of you want, who are watching, write down in the chat box. Okay, tell faster. Okay, I will tell you. Age, if the age is less than 40 years. So first of all, let's see what we will do if the family is not completed. If the family is not completed, then one has to not handle the uterus. उसे अभी कंसीव करना है तो हम यूट्रस के साथ छेड़खानी नहीं करेंगे. वी विल ओनली गिव स्लिंग्स टू, वी विल ओनली अप्लाई स्लिंग, ओके, एंड देन फिक्स इट, right? If age is less than 40 years and family has completed, a female like me, okay, less than 40 years, completed the family, but don't want to undergo hysterectomy for prolapse. In that condition, what we do is, in that condition, what we do is, this is the prolapse uterus. We cut the cervix. Okay, we cut the cervix. We cut the cervix. Okay, and then we take the both transverse cervical ligaments and stitch it to the anterior side of the uterus. This is Fothergill. Is it clear to you? What is Fothergill? Fothergill means amputation of the cervix and fixing the uterus with the Macken-Rodets ligament. Yesterday I told you mnemonic, how you will remember that once the family is completed, you will name that surgeries as Fothergill and Manchester. Family is completed मतलब फादर मदर बनना था बन गए, फादर मदर बनना था बन गए, ठीक है. नाउ नथिंग more, no more father mother, family is completed. So surgery name is Fothergill Manchester. What we are doing, we are amputating the cervix and we are fixing the anterior end of the uterus with the Macken-Rodets ligament, the transverse cervical ligament. Okay, if the age is more than 40 years and family is completed, then the surgery is Ward Mayo. Mnemonic is वृद्ध माँ. More than 40 years हो गए हैं, माता वृद्ध हो गई है, ठीक है. That way we will remember what we will do here. Then we remove the uterus. Then we remove the uterus. ना होगा बांस, ना बजेगी बांसुरी, ठीक है. ना यूट्रस होगा, ना वो नीचे आएगा. Other than uterus, removal of uterus, other than hysterectomy, what we do is, we do pelvic floor repair. As we know that along with the uterus, vagina wall also repairs, prolapse. To repair that thing, we do vaginal wall repair. If anterior vaginal wall repair is done, then name of it is anterior colporrhaphy. Anterior, you means anterior. Vagina, for vagina, the word in the medical language is colpo, and for repair, the word is rhexis. Anterior colporrhaphy or rhexis. Okay. Similarly, for the posterior vaginal wall, the name of the term is posterior colporrhaphy. Okay, I will not use Hindi. Okay, I will not use Hindi. Isra, is it okay now? Okay, we will focus on completing it fast. Okay, so only one joke I cracked, that if there will be no uterus, then who will come down? So we remove the uterus after 40 years. That's it. Okay. So there is a famous proverb in Hindi, I use that. Okay. So what is the treatment for anterior and posterior vaginal wall? Anterior colporrhaphy and posterior colporrhaphy. Okay. Okay. So now what has basically come down in the prolapse? Levator ani. So this is also known as pelvic floor repair. Okay. The last treatment is, because you all know that prolapse occur in menopausal patients, right? And menopausal patients, they also have other comorbidities. Okay, Isro and Shahrukh, focus here. Just forget all those things. Okay? Uh, because you know that prolapse occur in menopausal patient when estrogen tone is lost. Then levator becomes weak. So prolapse occurs. So at that time, patients, females, they also have other problems like diabetes, hypertension, MI. So 50% of the time, anesthetist says you cannot operate uh, on this patient because this patient is at risk. This patient has comorbidities. So in that condition, and what we do a very small surgery which is known as leaf forte colpoclasis. Okay, leaf forte colpoclasis. What is, how we will remember what is the mnemonic for it? See, we as a gynecologist, we work a lot, but that anesthetist just say you cannot do surgery, right? So our earnings have got hampered, but we are smart, so we told the anesthetist ले फिर तू, ठीक है? If you don't want to get the vaginal hysterectomy done, then you please get the done colpoclasis. Colpo means vaginal, clysis means adhesion. Okay, so if this is transverse section of vagina, this is anterior wall and this is posterior wall. So what we do is basically we fuse the anterior and posterior wall. This is leaf forte colpoclasis. Just that is it. So whenever the anesthetist give us a risk factor, then which surgery we do? We do it leaf forte colpoclasis. Okay. And if anesthetist says you cannot operate on this patient 5 minutes also, you cannot do leaf forte also, then we will give the patient pessary. Okay, then we will give the patient pessary. We will insert pessary. Is it clear to you now the treatment? Treatment is very important. That is why I have discussed it again today. Okay. So this is the picture of prolapse. As I told you yesterday that in prolapse, first the cervix will come out. This what I have shaded is cervix. Okay. Okay. Yes, answer to it is clear. Word mayo means vrid ma. Vrid means old, ma means mother. Okay. Okay. Now let us see the treatment of cystocele, rectocele and enterocele management. Okay. The treatment of cystocele is Shahrukh, yeah, it is right. D was the answer of this. Vaginal hysterectomy with pelvic floor repair. The answer was D. Okay. Yes. Cystocele, the treatment will be, and urethrocoel. Both of the treatment will be anterior colporrhaphy. The treatment of rectocele will be posterior colporrhaphy. But the treatment of enterocele will not be but the treatment of enterocele will not be colporrhaphy, right? There are two surgeries, McCall culdoplasty. Culdo means pouch of Douglas, okay, and Moshowitz repair. These are the two surgery for enterocele. Moshowitz has been asked in FMG. They can ask you this time McCall. Okay, please remember the operation name of these. This is, now let us discuss what is wall prolapse. Now when we have removed the uterus, see, I have done the vaginal hysterectomy. Now what this is left behind is the vault. Now this vault itself can come down, and when this vault comes down, it is known as vault prolapse, right? In the case of the vault prolapse, we have to fix the vault to the sacrum. So if any sacrum fixation surgeries are there, then it means they are the surgery of vault prolapse. For example, some of the names are mesh sacral colpopaxy, uterosacral ligament suspension, sacrospinous fixation. So wherever the word sacrum is there, it means that they are talking about the vault prolapse. Okay, they are talking about the vault prolapse. Now the last topic is pessary. Okay, what is pessary? Pessary is basically, these are the rings which are kept in the vagina so that the uterus does not come down, right? And in which all condition we put the pessary in the patients in which the operation cannot be done, even the leaf forte cannot be done, not accessible for operation due to any factor. Number second is in pregnancy. Number third is in puerperium. And number fourth is in emergency. This was asked in FMG June 22. When is in the emergency, what you will do for prolapse? We put the pessary in emergency conditions. In pregnancy and in puerperium, up till 6 months, we cannot operate. Okay, so in these conditions, we put pessary. These are some conditions, right? And pessary is put in pregnancy up till 18 weeks. After 18 weeks, we cannot put the pessary. Okay, we cannot put the pessary after 18 weeks. Is it clear to all of you? Okay. Now, how we will see? See, pessaries comes in different size. ठीक है, 4-5 size they come. Emergency like urine retention. No, it's not severe bleeding. Sometimes due to prolapse, the patient cannot pass urine, patient cannot or pass stools. Okay, right? For example, a patient comes in emergency with decubitus ulcer. To solve all those emergencies, we will put the pessary, and after manual repositioning, the patient can pass urine and pass the stools. Is it clear? Okay. Now, what is checking of pessary? It is again very important, as these are usually done by interns or first year residents. So they ask you this question: what do you mean by checking of pessary? See, I tell you, no female has a fixed vagina size. Okay, if we have put a ring of larger in size, then it will pain that lady. It will give pain to that lady. And if we have put the ring which is smaller in size as compared to her vagina, then that pessary will fall off. Okay. So we ask the patient to come up with 2-3 rings from the market. Okay. Then we insert that ring, and then we ask the patient that at is it paining? If it is paining, it means that it is of larger size. Okay? Presence or absence of discomfort. Okay? Then we ask the patient to perform Valsalva to increase its abdominal pressure. That is Valsalva. If it is falling with coughing, if it is falling with all of these things, then it means that it is small. The pessary is small. It will fall off. Okay. So dislodgement with Valsalva. We ask the patient to cough. We ask the patient to laugh. Okay. The pessary should not displace, right? And one test which is not written here is we ask the patient to pass urine. Okay, if these 3 tests are passed by the patient, it means that pessary is of good size and it will work enough. Okay. Now we will be doing urinary incontinence and fistulas. Okay, now we will be doing urinary incontinence and urinary fistula. What do you mean by the word incontinence? Can anyone tell me? What do you mean by the word urinary incontinence? You just tell me. You just tell me कि in urine incontinence urine comes out of urethra or vagina. In urinary incontinence of any type, it is of 4 types. If in urinary incontinence the urine comes out of urethra or vagina. Yes, urine in incontinence always comes out of urethra. If the examiner is telling you that urine is coming out of vagina, it means it is fistula. It is not incontinence. Incontinence means that urine is coming at inappropriate time, but it is coming from urethra. Okay. So there are 4 types of incontinence: stress urinary incontinence, Stress urinary incontinence means when the abdominal pressure is increased, then the urine comes out. When a patient laughs, when a patient cries, then the urine comes out. What is urge incontinence? Urge incontinence means that when the patient have urge, then the urine comes out. Before the patient reaches the loo, the urine comes out. Okay? Overflow incontinence. Okay, these two are rarely asked. Overflow means that there was obstruction. When the bladder get overflow, then only urine comes out. And number 4 is neurogenic. The muscle supplying the bladder undergoes damage. That is neurogenic bladder. Okay. Now you should know the basic physiology of micturition. Okay. This is the condition when the bladder is filling. When the bladder fills, then external urethral sphincter, it is contracted and bladder muscle is relaxed. Okay, which in the bladder filling stage, the sphincter, external urethral sphincter is contracted and the bladder muscles, it is relaxed. Okay, right? Bladder muscle, or you can say bladder, is relaxed. Okay, so external urethral muscle is contracted in the by the sympathetic nerve supply. Always remember. So when the patient is not passing urine, the sympathetic nerve supply is making the external urethral sphincter to contract, and this external urethral sphincter is nothing but levator ani, right? It is nothing but levator ani. And when a patient wants to pass the urine, when the bladder has filled more than 150 ml, then external urethral sphincter relax and this bladder muscle, this bladder, it contracts. Now at this time the nerve supply is of parasympathetic nerve supply. Okay, now let us talk about stress urinary incontinence. So in the physiology we learned basically that uh, when the bladder is filling, then sympathetic nerve supply is acting, and when the bladder is contracting during the micturition, the parasympathetics are active, right? Now what happens in stress urinary incontinence? The external urethral sphincter, or you can say the levator ani, it gets weak. Okay, so whenever the pressure increases, then the leakage occurs. This happens in stress urinary incontinence. Normal pressure is maintained by the weak levator ani, but when there is more pressure, like in coughing, laughing, all this time, then the levator ani cannot tolerate, the weak levator ani cannot tolerate that increased pressure, so the urine leaks. Okay, so what is weak in levator in stress urinary incontinence? Write down in the chat box. What is weak in the stress urinary incontinence? Write down in the chat box. This can be asked. In stress urinary incontinence, basically what is weak? external urethral sphincter, or you can say uh, the levator ani. Both are one and same thing. Okay? Okay? So now you tell me at what time the levator ani or external urethral sphincter will gets weak. With age, when estrogen tone goes, with parity, more the lady become parous, more the levator ani will get weak. Same prolapse etiology. Okay, more factors they have given to you: obesity, weightlifting. Okay, all are the same risk factors. The test which are done is stress test, Q-tip test, Bony Marshall test. What is stress test? Stress test means we make the patient to lie down, and then we ask the patient to cough. We ask the patient to, if the urine leaks, it means there is stress urinary incontinence. Okay? Okay, what is Q-tip test? See, on a swab, we put like this, एक स्टिक के ऊपर एक स्वैब लगा देते हैं. स्वैब स्टिक वी पुट इनसाइड द यूरिथ्रा. ओके, if that urethra angle is deviated, it means that it is the sphincter is weak. Okay, and the another test is Bony Marshall test. What we do in Bony Marshall test is, by we make the patient to lie in lithotomy position, and we put our two finger inside the vagina, and we strengthen the three swab test is for fistulas. No need to confuse incontinence and fistulas. Okay, okay Shahrukh, what is Bony Marshall test? Bony Marshall test is, we put two fingers inside the vagina, and then we strengthen the levator ani or the external urethral sphincter, and when we strengthen it, then the urine does not leak. This is Bony Marshall test. Okay, this is Bony Marshall test. With the help of two finger, we support the levator ani. Okay, keeping the two fingers anteriorly. Is it clear? Okay, now what is the treatment? If the female is obese, then weight reduction. Okay, next is Kegel exercise. What is Kegel exercise? Kegel exercise is pelvic muscle strengthening exercise. Okay, what we ask the patient to contract its pelvic muscles and count 10. Okay, to contract its sphincter, to contract its anal sphincter, to contract the urethras, to hold the urine and count 10. That is known as the Kegel's exercise. Now here comes the question: which drug you will give to the patient of stress urinary incontinence? As you saw in the physiology of micturition, that the external urethral sphincter muscle was, yes, the external urethral sphincter was supplied by which muscle? Which nerve? Which system? Sympathetic or parasympathetic? It was supplied by sympathetic. So we want that it should be more strengthened. So we give alpha adrenergic agonist. Is that okay? The drug which we give, the medicines which we give are alpha adrenergic. The sympathetic, we want the external urethral sphincter to be strong. So we will strengthen its nerve supply. So we give alpha adrenergic agonist, or we give SSRI or topical estrogens. Is it clear? Either we give sympathetic, SSRI, or estrogen topical. The surgery which we do is the sling surgery. Okay? Sling surgery. With the help of slings, we strengthen the levator ani. Okay? These days, two slings are there, TOT and TVT. TOT and TVT, transobturator tape and transvaginal tape. Out of these, transobturator is best. Okay? Transobturator is best. Okay? Okay? And the second number is TVT, transvaginal tape. These are all the strengthening surgeries. Slings. Okay? Next is the Kelly stitch. Next is the Kelly stitch. Okay, we put a stitch at the external urethral sphincter and strengthen it. The other procedures are abdominal procedure are Burch Colpo suspension and MMK. So I just remember this slings and TVT and Kelly stitch. That is only asked. Okay. Rest of it we will do tomorrow. We are left with fistulas only. Okay, and urge incontinence. Rest of it we will do tomorrow. Is that okay? If there is any problem, you can write in the chat box. Four to six. 4 to 6 will be the timing. Okay. Okay. The class is closed. We will again assemble tomorrow at 4 o'clock. Okay. 4 p.m. Thank you. Thank you so much.